I'm Ben Ryman, and this is Behavior Speak. In this conversation, Andressa Sleiman discusses the effectiveness of the TeachBack method in training behavioral skills, its impact on health literacy, and the importance of clear communication in healthcare settings. She highlights the challenges supervisors face in implementing behavioral skills training and presents TeachBack as a viable alternative. The discussion also touches on the integration of AI in behavioral training and the future directions of research in this area. All right, welcome to the podcast, Andressa.
Thank you for having me.
Yeah, excited. Before we get started, I just want to acknowledge I'm producing this podcast the lands of the Klaming, Tlehu, Somoko, and Comox First Nations. I'm grateful to be here. So, Andressa, why don't you tell me a little bit about yourself?
Yeah, so I was originally born and raised in Brazil, and I moved to the U.S. actually to pursue medical school. So ever since I was very little, I always wanted to go to med school. And through that journey, doing my undergrad, everyone told me, you got to major in something you're passionate about. So I was always intrigued by psychology. So I figured might as well major in psych. And I think similar to other people who started out as pre-med, I was enjoying it, but not fully loving all of my courses. And I just happened to stumble across Introduction to Behavior Analysis course. And that's when everything changed. And from there, I started my career. Like that really triggered along the line.
And so what were your early days of behavior analysis like?
So following that course, they actually had a brand new 7-week summer course for children with developmental disabilities. And it just sounded very interesting. And I remember going into the interview. To this day, I'm very shocked that they accepted me because I was like, I'm pre-med, I'm just here to learn. I'm just so excited. But everyone else knew what they wanted to do. But I'm so thankful they accepted me because that really changed everything. Because in those 7 weeks, I worked with 2 children. One of them, who his first words was actually saying goodbye to me. And I was almost crying. His dad was crying. And then from there, just seeing his language progress so fast in 7 weeks was like mind blowing. And then my second client, she actually engaged in a lot of self-injurious behaviors. And she went from headbanging like hundreds of times a day to 0. And I remember thinking, wow, I didn't do anything insane. I just followed the protocols. So following that camp, I was fortunate enough to be able to join that lab. So my early days were actually around children with severe problem behavior, a lot of food selectivity, so a lot of work with children with developmental disabilities. But I was still pre-med. So when I graduated, I was still studying for the MCAT, ready to go. But part of that journey, I was shadowing a lot of doctors. And that's when it really clicked that I didn't want to be a doctor every single day. And instead, I wanted to help the patients because the doctors would even tell me, I just gave them this diagnosis. I'm going to ask them to change their diet and exercise. They're not going to do it. They're going to come back. They're going to be needing medication. So instead of being a diagnostician, at that point, I realized I can use behavior analysis in healthcare to really help patients and even seeing issues they had internally in the clinics. I'm like, surely there's some things that we could do there. But I still didn't really know what OBM was. So I do specialize in organizational behavior management. So it wasn't until my master's, which I went to Florida Institute of Technology, where I currently work actually, where I majored in behavior analysis and OBM. And that's when it all clicked. It all came together where I could see combining my 2 passions of behavior analysis and healthcare and my other interests.
It's wonderful. Yeah, I was wondering about how you sort of started doing the work in sort of hospital settings. Before we get into that, maybe just tell for my listeners that maybe not be as familiar with some of these things, what is organizational behavior management?
So in very high level terms, I like talking about OBM as the application of the science of human behavior to organizations. So how can we make the workplace more productive, safer, with happy workers. And I think all three are very important because we do need workplaces that are going to be successful and generate an income, so the doors are open, but not at the expense of the worker. So I'm very passionate also about making sure that workers have some level of satisfaction and behavior-based safety. We don't want to be causing any injuries in the workplace. And when I first heard of safety, I remember thinking like, oh, it might be a little bit boring. But then when I started to really realize the impact that it can have, I find it fascinating how we do have so much control over the environment that we can truly make an impact and make sure that people are being safe. And it's a spectrum too, right? So all the way from like chemical manufacturing companies, but also in like working in an office, working in a computer. If you don't get up, you don't stretch, you don't eat well, like that can lead to like back pain and other health issues. Or even with registered behavior technicians in the US working with children with disabilities, I've actually seen a lot of them have like back injuries where then they need to be away for a long period of time or they leave the field altogether.
Really cool. And so do you do a lot of work in this behavioral-based safety area?
I've been doing a lot of applied work, yes. So if I have to categorize my interests, they are quite varied actually, but I'm very passionate about healthcare. So how can we improve adherence of clinicians to best practices in healthcare, as well as like the patient themselves? So I group that together, healthcare. The second major interest is safety, so behavior-based safety. And that's across any industry, so not just healthcare. And then the last one, I kind of group them together as like communication, because in OBM and like with verbal adults, a lot of what we do is communication. So feedback, TeachBack, building rapport, coaching, those are all verbal communications. I kind of group that together. So I would say those are my three bigger passions that I've been doing either research on or more like applied projects on.
Well, those are, you kind of touched on a couple areas on sort of how I found you were a few studies that I thought were kind of fascinating. We don't see a lot of this work in talked about in behavior analysis, particularly in the context of kind of hospital settings. And the first study was kind of related to sort of improving something called rounding in hospitals. And so can you tell me a little bit about, first off, what is rounding and then the kind of work you were trying to do there?
Yeah, absolutely. So I can't talk about that study without giving credit to my advisor, of course. We did that project during my Ph.D. at the University of Florida with Nicole Gravina, and she also has a big passion for healthcare. So once she started there, I was her student her first year there. So we were really focusing on building those relationships in hospitals and healthcare. And through that, they identified the need. The hospital identified the need where it was a generalized unit, meaning patients that would go into the emergency room, but they ended up being admitted to the hospital. That's usually the unit they would go to. So those are patients that are probably only there for like 3 days, like a week. If it becomes something else, they're either going to be discharged or moved to a different section of the hospital, different unit. So in that, the doctors, they had to go and talk to all the patients and see how they're doing, make sure that they're receiving all the medications that they need, request any labs or tests, with the ultimate goal of discharging them. And what we were identifying, what we did see in baseline data is a very large number of variation of what the doctors were doing. And just to explain that a little bit better, how it worked in that unit is doctors worked 7 days on, 7 days off for 12-hour shifts.
Okay.
So each week, a new doctor would come in. So it's not like it's the same doctors in that same unit. And that's why we were able to see so much variability across doctors. And there were 2 units and 2 doctors at a time. So in a day, we could see four different doctors. And what we saw is that some doctors are high performers. They would round with every single patient in the room with the nurse. And they were able to really align the communication and align the treatment and do what the expectations were. However, there were other doctors that didn't round at all. They would just round on the computer. They never even saw the patients and everything in between. And I'll give you a specific example of a time where a doctor was talking to the nurse outside of the patient's room, and the patient heard, and they were very offended, rightly so. It's like, I'm in here, like, come talk to me inside the room.
Sure.
And so they would round outside the rooms, and then the doctor would go alone inside, talk to the patient. So what the standard was, what our whole intervention was, is that the doctor should be rounding inside of the room with the patient, their caregiver, if they were there and they allowed it, of course, the nurse, the bedside nurse, and if possible, the charge nurse. So everyone should be rounding together. And then the hospital have this acronym, which is TEMPS, and they should talk about each individual item on the TEMPS list. So T stands for, see if I remember, it's been a couple of years, telemetry and tubes. E, eating, exercise, excretion, was monitoring, so monitoring lines, how often you do blood drops. And then P, pain and plan for the day. So they had to touch upon all of those. And why that specific acronym? It comes from best practices that was identified in the literature. So that was decided by the hospital, not by us.
Gotcha.
So what we did was, how can we get doctors to actually do that?
Really cool. Okay, so let me see if I get this right. So in this particular hospital, doctors are supposed to do rounding, which essentially means kind of checking on all their patients. They're supposed to follow this TEMP checklist, which is sort of a series of criteria that hospital decided were important to sort of get the information they need to get during each round. But doctors were doing this in sort of different ways. Maybe they weren't even necessarily even getting through the whole checklist. Maybe they weren't actually meeting with the patient. Maybe sometimes they were meeting about the patient in earshot of the patient, which can always be a problem. And basically, no one is sort of doing this the way it was intended. Is that pretty much kind of what was happening? And so and I want to kind of get into later on sort of even how you ended up in a hospital in the first place. But for the sake of this study, how were professionals trained on this in the first place, sort of before you got there? Do you have a credential with the International Behavior Analysis Organization, the Qualified Applied Behavior Analysis Credentialing Board, the Behavior Analyst Certification Board, or would like a certificate of attendance for another organization? You can earn one continuing education unit by going to www.behaviorspeak.com, clicking on CEUs, and entering the 3 secret words. The first secret word is rounding.
Before I got there, they definitely got trained like when they started in the hospital at some degree. So you can imagine that could be the doctor just started. It's fresh in their mind, but if they didn't, it could have been years ago. But every time they started the week, their supervisor actually emailed them the expectations for the week. And in there, they had this manual that talked about temps. And I remember when I was first sharing this study in my university, everyone just asked me, why didn't you just tell them what to do? I'm like, that's a great idea, but they knew what to do. That was not the issue. So absolutely, first step is tell them what to do. But even when we talked about with the doctors, they did know what to do, even though our first intervention involved test clarification and prompting. They knew what to do. And that's why our prompting did increase, but it wasn't until we added it. I'm sure we got to intervention a little bit, but it wasn't until we added a feedback that we really saw that bigger increase.
And so essentially, at the beginning of each week, they just got sort of a written email saying, okay, here's what you're supposed to be doing. It was probably the same email they got every week, so that probably got a little bit...
Yes, but they didn't work in the same unit every week. So they worked 7 days straight for 12-hour shifts, and then they did not work for 7 days. And then they came back for 7 days, but it could be also time it was a completely new area of the hospital.
But regardless of the area of the hospital, they were checking their checklist?
At the time of the study, they were really focusing on the temp checklist in the units that we were in. With the idea was identifying ways to like really get doctors to use it and then implement it across other units.
So this was essentially the pain point that kind of brought you in and said, hey, folks aren't doing this. How can you help? So what was sort of the first thing you did in this study to sort of try to solve this problem?
Actually, the first thing, which I don't think it comes across in the paper, was even doing the checklist and identifying what behaviors to observe. Because when we first talked to them, they're not behavior analysts. The way they collect data is just a little bit different. And what they wanted us to do is to go in and they would see 15 patients a day and observe the 15 patients with the doctor and then give it a qualitative score from 0 to 5 of how well they did. And you can imagine that would be extremely biased and very challenging to measure. So from there, we started playing around with the different things, the different ways to use the data collection tool. And it took us 4 months actually to go and observe and talk to them. We did partner also with a medical resident. I think she was a student at the time or a resident. I do apologize, I don't recall. But she taught us the terminology and we worked collaboratively. So it was not just my lab alone. We did work collaboratively with them. And so it took us 4 months to really identify what are the behaviors that we want to look at. So that was the first step that we did. Following that, we collected baseline, even identify, is this really an issue? And it was. We did identify that it did require intervention. So from there, we did interviews. Nicole Gravina actually did a modified version of the PDC, the Performance Diagnostic Checklist, where we got inspiration from it, but we created our own questions based on our current needs. So we asked questions around the 4 main domains to a high performer physician, a low performer physician, the charge nurses, and then the main supervisors. And through that, we identified a couple of barriers. And that's how we selected our first intervention and then subsequently our second intervention. So we did want to be as least intrusive as possible. If we could have increased to 80% or 100% with test clarification alone, that's always ideal. But we ended up needing to add some feedback.
Okay, so tell me about the sort of the key interventions used in the study.
So our first intervention involved test clarification and prompting. That's where we gave them a little bit of feedback on how they were sending out the emails to make it more salient. And then the clinician supervisors, he verbally had meetings every week to remind them to do it and to get feedback on how I was going. And then when we were there collecting data, we would first ask for permission. Even though we had permission to be there, we still ask for each individual doctor. And then we just reminded them, like, this is why we're here. This is the checklist that we're going to be collecting data on. So there was no hidden surprises on the data that we were collecting. We even gave them a couple of checklists because the goal was really to increase it and not to, it wasn't a secret, right? There were attempts everywhere and little cartoons of the acronym and what it stood for.
So this first intervention, if I'm hearing you right, you're essentially giving them what the temp was and that you were taking data on it?
Yes.
And so just their awareness that there's someone in there observing them taking data was the intervention?
Yes.
Okay. And so what did that do?
Actually did increase by about 25%. 25%. And I do want to add, though, that although some physicians were bought in, not all of them were, but all the nurses were. The nurses actually really enjoyed this intervention. And again, with some liking it more than others, obviously, but they really liked it because now they were involved in the conversation. And it's not like the doctors talked to the patient separately, and then the patient later on asked the nurses, and they didn't know what they talked about. Now they were all involved in the conversation. So the nurses were better able to take care of the patients.
Sure.
And also the doctors started reporting less calls to them throughout the day because now the nurses also knew what was happening.
Perfect.
So there were some also naturally occurring consequences by the doctors that were doing it. And I think if we had been able to make sure that every doctor contacted that and every nurse contacted that in that phase, it would have naturally reinforced that behavior.
Yeah. And so what'd you do next?
So next we gave them feedback. And after each session, after each observation, we asked the doctors and the nurses, would you like to know how you did? Would you like the feedback? And they would say yes. Some actually were curious and wanted to hear it. And some would say yes and kind of roll their eye. But regardless of their reaction, that's when we saw a bigger increase in behavior change. So looking at the paper, it increased by 31% and 44% in the second unit. And unfortunately, COVID hit. So that project and other projects that we had going, we stopped. We had to stop them all, obviously, and especially in those units where they were the ones accepting COVID patients. So I don't fully know what would have happened if we stayed there. I know that right now, my advisor, Nicole Gravina, they're doing follow-up data there and doing different forms of interventions. So it would be interesting to bring her in a future episode and see how similar or different, like what kind of other interventions they put in place. I do need to ask her how it's going.
Yeah. And so the sort of the final outcome you don't really know because of COVID. Was there sort
But
of
we did see, sorry,
no, please.
we ended up publishing the paper as the behavioral data, but we were still curious about the other metrics. So with COVID, they were obviously really busy with COVID, so we never got access to that. But once things calmed down, like years later, we did, and we published it separately in a medical journal, and we did see positive impacts. So for example, the length of stay decreased. Should probably pull up. So I'm giving you all the accurate data as well for that one. But
that's cool.
So there were other metrics as well. So a couple of the metrics that we did find was, I apologize, that's the wrong one. Thought I had it open before we started. All right, so this study, we actually published it in VMJ Open Quality. And what we found was that the implementation eliminated central line associated bloodstream infections and catheter-associated urinary tract infections. That is one metric that we found. I actually had a previous study on catheters infections, and what we found was that the longer you have it in the lines, like anywhere in your body, not surprisingly, higher the chance of getting an infection. So what temps would do is it would make sure that they have that conversation every single day. And that led to people removing it sooner. Not sooner than the patient needed, but actually removing it when they no longer needed it. So that inadvertently reduced infections. So that was one metric that we found. Another one, we reduced an average hospital length of stay of 13.3 hours, with a second unit achieving 23-hour reduction, which is actually a lot because they were almost always at capacity. So that just means that now you're able to see more patients at that same amount of time. And we were trending down to 30-day readmissions rate, so decreasing it. It wasn't quite statistically significant yet, but the trending was going down. So that's the percentage of patients that returned to the hospital within 30 days for the same diagnoses.
This is really cool. So, because none of the actual, nothing you did in reduced sort of infection or reduced stays. This is a temp procedure that's come up by the hospital. And so clearly someone in hospital land knows that if folks are doing this stuff on a regular basis, you know, the patients are going to get the best care possible, the lowest risk of infection, the lowest risk of return, so on and so forth. Problem is people just aren't doing it. And so they are getting that follow through. And so, you know, this is just essentially showing them that their temp idea is a good idea if people would just do it. And so I see also a benefit here, and maybe this is part of the reason you're able to publish in a medical journal, is that you're really showing the effectiveness of these medical sort of I don't know what you call the temp thing in terms in the land of medical worlds, you know, medical administration or our doctor administration type strategy. You're showing that effectiveness. And so I'm guessing that sort of prior to you folks coming in, these strategies were just things people came up with that didn't really have any maybe necessary research to back up their effectiveness?
I'll argue the opposite. I think the medical field has done a very, very good job at identifying best practices to increase patient outcomes and decrease injuries and decrease all the negative aspects of it. However, they're missing the behavioral component of how do we get people to follow it? So this is where we as behavior analysts can really help, which is how can we increase clinician adherence to these best practices? So in parallel to that, I was actually doing an internship in the hospital. It wasn't a behavioral internship, but it was all quality improvement. And that's actually where I learned a lot of the best practices that hospitals do have. So I'll give you another example of a study we published through that internship, which was following a hospital stay. This is a completely different unit. Following a hospital stay or even following surgery, if you call the patient back within 48 hours, it has a ton of positive outcomes. But what was happening is the nurses, they just have so much to do that it's just, they did not have time. So part of that study was, can we triage that by having, at the time, an intern call the patient first? If they say, no, I'm all good, I don't need anything, they're good to go. If they needed follow-up help that was administrative, so either rescheduling appointments or billing, they would pass that information down. And then if they did need follow-up with a nurse, they would pass that information down to the nurses. So now the nurses, instead of having to call 100% of the patients, they only have to call a very small percentage back, which made it manageable. And that, again, we saw a significant decrease in 30-day readmission rates.
Really cool. Neat. I really haven't heard about I've heard about behavior analysis in hospital settings, sort of in the context more of kind of psychiatric hospitals and, providing, behavioral supports direct to clients and so on and so forth. But I haven't heard a lot about sort of this kind of OBM work in hospitals. How did this and this would be a better question, I suppose, for Dr. Gravina, but how did this kind of work start in the first place? How did behavior analysts get into the hospital setting and build these relationships, start doing this kind of work?
That's a good question for her, how she actually created that first interaction. But if I remember correctly, she cold emailed different people in the hospital. It did take a few different people. It wasn't the first one. But then she identified one specific person who actually he created a whole course on it and sold it online for about increasing quality and increasing adherence to these best practices. So when she did a really good job at researching and identifying the stakeholders, so she already identified someone that would be open to these ideas because he was already doing it. And then in parallel to that, the internship, it was a full internship at the hospital setting. So it was also something that was searchable. And then she was able to put me in contact with them, and being a grad student definitely helped, because then we're like, we can help with these things, and just really build that relationship. And then once we have built that first relationship, and did that first project, it opens up more doors for other projects. So the exact details, I do have to defer to her, but a lot of researching, identifying the key stakeholders, and being good at networking, I guess.
So really I think I definitely will talk to her. Really, this just started with, as you say, a cold email, just sending out messages, looking for folks that might be interested in improving their practices. That's amazing.
Yeah.
Okay, so the other area that I wanted to talk to you about is this TeachBack method, and this sounds like this is also a practice that kind of comes out of the healthcare work. So tell me about sort of what the TeachBack method is, and how you discovered it, and then the kind of work you started doing with it.
Yeah, absolutely. So how much time do we have? Because I could talk about TeachBack all day long. By now, all my students can talk about it all day long too. But the first time I actually heard about TeachBack was during that internship in a hospital, where it's best practice. And I don't even know, there's probably thousands of studies showing that when clinicians use TeachBack, it produces so many positive outcomes. So TeachBack is what the name actually sounds like, where clinicians are expected to explain one chunk of information at a time and then ask the patient to explain it back to them using their own words. If there's no correspondence, then they should explain it again using different words until the patient is actually able to repeat it back. So very simple in the sense of it's communication. It doesn't require additional resources other than time, of course. And there are so many studies that show that when they do that, it increases reported satisfaction, it decreases 30-day readmissions rate, it increases adherence to treatment, decreases in callback, canceled appointments. And we can theorize why, being that now if the patient truly understands the recommendation, they're able to follow it and feel better and then come back or not have to come back. So it's really about clarifying information, TeachBack. That was actually my original dissertation idea, which was I had a really great methods planned out. How can we increase clinicians' use of TeachBack in the hospital setting? And due to COVID, we're unfortunately not able to do it. But through conversations with Dr. Gravina, we were thinking, well, where else can we apply this? Like, it's just clarify information. It's so effective. What about in training? So that's what a part of my dissertation was. Can we even use TeachBack to train people new skills? So we recruited 13 undergraduate students, and we trained them in using TeachBack how to complete an MSWO, a paired stimulus preference assessment, and a token economy. So one participant only learned one, except for one person that actually learned 2 skills. The reason why we picked those is because the preference assessments are commonly studied in behavioral skills training. And then we picked token economy because it requires more steps and more skills. So once the other one started working, we're like, can we use this to teach like more steps? And I was surprised when we did. We got 100% of participants reaching 100% criteria, either with TeachBack alone or with TeachBack and feedback. Idea behind it that I'm very passionate about is that we know behavioral skills training works, right? If I ever have a student that tells me, I want to study behavioral skills training to teach blank, I'll tell them it's going to work. Because by definition, you're not done with behavioral skills training until they meet mastery criteria. But what the data are always also showing is that supervisors don't have the resources or the capacity to do it. So they're not using BST. So are there other strategies that supervisors can use to train their behavior technicians, but that will require less, like no real formal resources other than time, and have them learn the skills? So really that's where that all stems for. And so far, I'm very surprised with the positive reaction we're getting, because we published that study last year, and so many people that I know have replicated it, and they're on the process of publishing it. So that I personally know of, there are like 10 different studies from different labs. Some are from the same lab, but not my lab. That's what I meant. That replicated that study in the applied setting at some capacity. So for example, I have a colleague that she demonstrated TeachBack was effective on training registered behavior technicians how to do naturalistic training. Another colleague on how to teach RBTs how to do multiple schedules. So like they're like in the applied setting, and we're seeing the same patterns. They either reach it with 100% TeachBack alone, or with TeachBack plus on-the-job observation and feedback, which is best practice. Regardless of BST or not, the supervisor should still be observing in the natural environment and providing feedback.
Wow, that's amazing. So it blows my mind that sort of in the medical field, that the idea that, because we often hear about patients that, don't follow doctor's orders. Their doctor tells them to do something, they don't do it, they go home. And then we just sort of get the idea that, well, there's no buy-in or get or whatever. But it sounds like for at least a lot of these thousands of studies, it's just they didn't get what they were told in the first place. And for whatever reason, maybe time or embarrassment or whatnot, they didn't ask for clarification and went home not really knowing what to do, or went home maybe knowing partly what to do, or maybe went home thinking they knew what to do but did it wrong. And
yes,
that's just mind-blowing, that being able to explain it back in their own words led to so much adherence. So I could see why you wanted to kind of bring that to the field.
And I can give you an example of something that actually happened, where a patient was diagnosed with hypothyroidism, I believe it was, if not mistaken, and they came back, and then the doctor was asking how's the medication going, and he said, oh, I haven't been taking it because I haven't been feeling hyper. So he understood that whenever he was feeling like euphoric, that's when he had to take the medication.
Sure.
But hyperthyroidism has nothing to do with that, obviously.
Yeah.
So even like using plain language and things like that plays such a big role. There's a little bit of older data. I would actually love to see someone get newer data for this, but half of what is talked about is forgotten immediately after an interaction with a clinician.
The second secret word is...
we can also talk about having low health literacy, which is the capacity to learn and comprehend health information. But beyond that, I consider myself to have very high health literacy. My mother was a physician, so I always heard medical words before. I was pre-med, so I took a lot of pre-med classes, including medical terminology. But when I was in the hospital, when I was seeing a clinician and he told me that I needed ankle surgery, I didn't remember anything else he said. So we're all made vulnerable by when you're sick and you're not feeling your best. So even if you do have high health literacy, you're still vulnerable to not retaining or understanding what they said accurately.
Well, I can imagine, just being in a hospital setting and, maybe it's a point where you receive like a very scary diagnosis.
Mm-hmm.
And then suddenly your brain is just, off in, anxiety land, thinking about what my future is going to be like. I think about like a cancer diagnosis, maybe. My brother's an oncologist, talked a lot about sort of that experience. And, they often even show it in the movies, the patient has just been told they have cancer. The doctor now tells them all the things they're doing, but they fade out the audio, so it sounds like a mumble because the patient's off in the zone thinking about, oh no, I have 3 months to live, and so on and so forth. And so all that information is just sort of going past, and then of course you say, yeah, so you understand what you're going to do? Yes, doctor, and you leave of anguish and pain. So the idea of sort of just repeating what the doctor said kind of puts it right back to the forefront.
Yeah.
Yeah.
Love asking, whether I'm talking about in terms of training or even healthcare, how many of you had a doctor actually use TeachBack? And I might get one person, maybe two if I'm really lucky, and it's usually like one specific doctor. So it's effective, but they're not using it. And a couple of the reasons why they say is like it takes longer, which it is true. If you're using TeachBack, it will take longer, but it will be shorter in the long run because if patients are needing to come back less and less, and you're able to see more patients for different diagnoses. The second one was that they said that patients don't like it. So that was actually part of my dissertation. The way that I worked at my university is we did 3 smaller studies. So the first was the one that actually was the third one was the teach back to train new skills. But the first 2 was actually an acceptability study. We first did it with undergraduate students, and then through Prolific, which is a way to access like a broader population. And we had different videos for 2 separate diagnoses. And then for each diagnosis was multiple sclerosis, and then the second one was diabetes. For each of them, we had 4 different interactions. The first was a clinician using jargon alone. The second, plain language alone. The third, plain language plus TeachBack, and then jargon plus TeachBack. So they watched each participant watched one interaction for the multiple sclerosis diagnosis and one interaction for the diabetes. And the order was counterbalanced and randomly assigned, all through Qualtrics. And then they were asked to rate their acceptability and a couple of other answers. And what we found was within our population, within those specific videos, was that actually the patients all reported favorably towards plain language and TeachBack. But what really mattered was using plain language compared to jargon. So at a minimum, we show that plain language plays a really big role, which makes sense. And then they either do prefer with TeachBack or they don't dislike TeachBack. Now, with the caveat, of course, that we did the best practice that we could. And in practice, I can definitely see a clinician maybe being more condescending in how they're using TeachBack. And we haven't even touched that yet. The different qualitative aspects of using TeachBack, or how often is it more for new information or for repeated information? So there's so many questions yet, right? That was like the first one. I have like a laundry list of different studies that I would like to do around TeachBack, but I think that's very promising. And I have this theory that by using TeachBack in and of itself is going to increase your plain language. So that's the next study we're actually working on the methods right now, because if you explain something and I ask you, do you have any questions? And you say no, then I'm like, I'm awesome. I did such a good job explaining this. Like, I don't need to change anything.
Yeah.
And that happens with my students. Like, any questions? No questions. I'm like, all right, so repeat it back to me. And that's when I start seeing the parts they didn't quite get. So by doing TeachBack, by asking that, then I explain it again using different words until they're at a minimum able to repeat it back accurately. So the last way that I talked about it gets reinforced. So I think it's a natural way of shaping verbal behavior in a way that the patients or your supervisees or any person really will understand.
Yeah, I had a supervisee a while back, and I learned a hard lesson was that them telling you they understand doesn't mean anything because
No.
it turned out they didn't. And they kept saying it sort of throughout the process, even as they were making errors, and other supervisors were trying to provide corrections and feedback. They go, "Yep, now I get it. Yep, now I get it." But every time the permanent product was, no, they didn't get it. They're still delivering the same problematic sort of outcomes. And so, yeah, no, it really makes you think because it really does reinforce your own verbal behavior.
This talk I've done it a couple of times where I talk about like the importance of building relationships, and my theory of one way of building a good relationship is to first give clear expectations. Like you need to know what you want. The second part is attainable expectations, because sometimes we want too much that is just not viable. But then the third is, did they actually understand it? So that's where TeachBack comes in to make sure they understood those expectations, because if I have the correct instructions or the correct rule governed behaviors that we're going to follow, then I'm more likely to contact reinforcement and have a better relationship with my supervisor. But if I think I understood but I didn't, or I'm too scared to ask for clarification, then next time my supervisor sees me, they're more likely going to provide constructive feedback. So I also think that over time, it's going to strengthen relationships, because now you're able to provide more positive feedback to your supervisees, or positive praise, or whatever it might be, instead of you having that same conversation with your student of like, again, another error.
Yeah, for sure, for sure. And also thinking about kind of even how it, I'm sure this is probably someone on your list about how it kind of shapes your own plain language, because I would think that, if I'm plain language is a pretty subjective kind of term in and of itself. I mean, it's
Mm-hmm.
one thing to sort of not use super technical, in sort of in the field of behavior analysis, sort of super technical behavior analytic jargon. I was finding this sort of, I found this sort of like, for example, in like when kind of positive behavior support kind of first came about, and they tried to sort of remove all of the jargon and bring in terms that were sort of more understandable to folks, but in the end, really just ended up creating a whole new set of jargon, and talking about like sort of setting events, antecedents, all these sorts of things, terms that we don't use in sort of everyday language, and so I feel like the TeachBack piece really helps kind of shape what sort of makes plain language almost kind of culturally responsive in a way, because what I think is plain language might not be plain language to you.
Absolutely. So that is what we're trying to work on right now. It's just the methodology. I have a lot of different ideas of how to do it, but it's a little bit challenging. So that's what we're currently fleshing out right now. But it's my number one study that I want to do, is showing exactly that, of how does using TeachBack shape your own verbal behavior to include plain language, and then of course separately, how does that impact the behavior of. So we're still deciding on like the setting that we want to go with. Is it more like supervision or more like medical? And is it with undergraduate students to flush it out first and then go to the more applied settings, or even around safety? Like the are endless, I think. So that is exactly what we're trying to work on right now.
So it sounds like from the studies you're doing and the replications that TeachBack can be as effective as behavioral skills training in a lot of different contexts. Well, let's talk about, for folks maybe that first off don't even know what behavioral skills training is. Maybe we can talk a little bit about what that is, and then talk about sort of what's now the advantage of using TeachBack over behavioral skills training, and what were some of the outcomes you could have found.
Yes. So I do want to have the disclaimer that I do like behavioral skills training. I don't want to be seen as that I don't enjoy it. I just think that there's a time and place for different types of training. So behavioral skills training is a specific type of training where you first explain the skill that you're going to be teaching, like didactically, like usually with a PowerPoint or just written instructions, some sort of instructions. Then you model the behavior. You ask the trainee to rehearse, so they practice, and then you give them feedback, and then they practice again, you give them feedback, they practice again, you give them feedback until they're able to show the skill with fluency. So that is why it is considered the gold standard best practice of training. It's BST, or behavioral skills training, because by definition, you're not done with the training until they can show you the skill. So by the time you're done with the training, they learned the skill, right? Otherwise, you're not done. Like, you keep going. However, it takes such a long time. For example, with the preference assessment, I found a study that said it took them 8.5 hours to teach them how to do a preference assessment. And in hours, the entire study took about an hour and a half. But the actual TeachBack part was 11 minutes. So I believe, and again, we need studies to test the boundaries of efficacy. I believe that there are always going to be some skills that you'll need BSD for a lot of them you won't. So I'll give you the example of anything safety related. Learning, if you're working with children that exhibit a lot of challenging behaviors and you need to learn different holds, then I highly recommend you first practice that a lot and build that fluency. Otherwise, you can get hurt and your client can get seriously hurt. But for something like preference assessment, I don't think you need to go through the whole BST. If by clarifying instructions and then giving feedback, you can get there. I will also say that sometimes it can come across as condescending. And I had a supervisor once who, she was like, I'm going to engage in best practice. We're going to use BST for everything. And I had to submit a form online. And she's like, okay, let me first explain to you. This is where the form's located. Now let me show you. All right, now you do it. And I know she had the best intentions ever. And she was my supervisor. I actually did like her. But it came across as like, I didn't need that level of training for something like submitting a form that it was a normal form. It wasn't like your tax form, you know? So that's where I do see the value of TeachBack coming in for those other types of skills, where it's really about clarifying information.
Okay, so what's sort of the next phase here? We know it works. We know it's great. I know I'm going to start using it because it just seems really a lot more efficient. I mean, just a little bit of kind of the work we do. I work for a positive behavior support agency, and we provide behavioral supports to families and agencies through government contracts. And so it's a very limited service. I know in some of our regions where we're providing maybe just 3 to 4 months of services for a really kind of severe challenging behavior generally in community contexts without RBTs. Only parents as caregivers or sort of direct support professionals that kind of come out of community living. And so we're really looking to sort of get some really basic strategies in as quickly as we can, generalized and skills transferred. And then we're out of there. We're not available for follow-up. It's a very limited service. And so recently, and we're in Canada, and so we don't have licensure and whatnot for the most part, except in Ontario. And so there's not a lot of regulation around things. But recently, some of the government bodies have started to bring in more kind of behavior and analytic language into their policies, which is great. They're actually requiring BCBAs or folks at that level for really kind of severe safety planning and whatnot. So that's been good to see. And recently they put out their new policy manual, brand new, and it said that everyone's got to use BST.
Yeah.
Which I love that they're using, some of that evidence base. But for us, that's going to be really tough because, as you say, for a really intensive type intervention, it could take many, many hours to sort of just train on one skill. And we're not even going to get to sort of we're not going to get our plan implemented in time if we do everything through BST. And so we need some of these other methods in place. And so I love that this is here, and I think this is something I'm going to be able to bring back to those folks and kind of have conversations about sort of, how about you maybe using evidence-based strategies to sort of train things versus, being really specific about this gold standard, because I think BST has really gotten, a lot of hype as the gold standard. Without sort of really thinking through, the time it takes to implement.
Your revision of the word evidence-based training. Because as much as I do love TeachBack, and I think it can be used for almost anything, there are also other types of effective training. So, for example, online training, like self-paced trainings, or like BST does work, obviously, but depending on the task, I think there are other types of trainings as well that can be considered.
So what's next for you? What you talked about some replication. You talked about a big long list of things kind of going on. What's next for you in terms of the TeachBack method, and then just other projects you have on the?
Yeah, so I guess I didn't talk about that in the beginning, but I'm assistant professor at Florida Institute of Technology, and this is my second year. So it's kind of an exciting time to be here because now I'm really trying to answer that exact question of like, what's the next 10 years going to look like? So definitely a couple of different lines of research. So the first I'll talk about is TeachBack, which is now we know, and things are going to start getting published soon, I hope, that TeachBack in the methodology that I used is being effective. But our baseline always involved written instructions. So actually what my thesis student is doing right now, we're about to propose his thesis, is doing a group design. And it's a group design to teach financial literacy skills to undergraduate students. So a little bit different setting. One group's going to get normal didactic training. The second group will get the same exact training, but with TeachBack. And then within each group, it's going to be a teaching will be held in groups. And that is because in real life, most of these types of training would be happening in groups and not one-on-one training. So that will be done evaluating the effectiveness of TeachBack in a group setting. That would be novel. And doing it through Zoom, that's novel. So I think there's so many other questions of different formats. And even within the group, do you ask every single person in the group to repeat back or just one person? So we're making a couple of arbitrary choices right now, of course, based on being conceptually systematic. But I do see that leading to a whole other line of research. And then, of course, also looking at how does that shape your own verbal behavior. So those are the two that I'm currently working on right now, but the list is endless of ideas. In terms of healthcare, I'm actually partnered with Performance Ally. They are a software company. It's really cool, actually, because one of the biggest limitations that we had in the rounding study and other studies is that we can only collect data when we're there. And what Performance Ally has developed is a platform where the patients can give feedback to the clinicians in real time. So what if we can introduce these interventions, but get real-time feedback from all the patients? So that is something that's slowly happening, but we are partnering with that. And I do have a couple of other projects that are healthcare related with them. And then the list is endless. We also have some safety projects and then always guiding the interest of my students. So right now I have a student very passionate about restaurant business. She wants to graduate and go into restaurant business. So we're working on that. We're actually working on a literature review right now on clinician safety in healthcare. So a little bit of a varied topics.
You also mentioned before when I kind of last was healing back for you, you're getting into the world of AI a bit. Can you tell me about that?
The third secret word is teach.
Yes, definitely. So actually with Performance Ally, we know that pinpointing is so important. And that's like one of the big keys is what do you even want to measure? What do you even want to get feedback on? So a project that we're currently doing right now is asking the question, can AI provide feedback to pinpoints and then use that as training to improve people's pinpointing behaviors? So we're going, we spent, oh my gosh, a whole year just working on prompt engineering. And it's been like a very interdisciplinary team. And then now we are ready to kind of like test that out. It's going to be part of a student's dissertation, actually, on one, do we have IOA between a human and the ChatGPT's scoring? And then two, which so far we do actually have pretty high IOA, thankfully. And then the second one is receiving feedback from a human and then receiving feedback from ChatGPT. Can we increase their accuracy in pinpointing? So that is another fun study that we're doing, but I'm very intrigued by AI and everything that it in different ways that it can enhance things in healthcare, in teaching, in all aspects. It's obviously all changing very rapidly, and the capabilities are changing very rapidly. So I know we're going to be seeing a lot more guidelines soon of what is considered ethical, what isn't, at what level can we use it or can we not, to guide like even intervention practices. I recently saw a program that used AI to summarize, to help BCBAs create their plans for their clients. So basically the BCBAs would do the assessment, upload all the information. AI would provide recommendations for programming, where then BCBAs can take that and then create their BIP. And I'd be curious to know how well that is accepted by BCBAs, by parents, by RBTs, how much better or worse it is compared to a BCBA doing it all by themselves. Does that mean now we can see more clients? I just have so many questions, and it's a cool time to be doing some AI studies, I think.
Absolutely. Well, Andressa, I think right now you're asking a lot of questions that are really important, and really kind of looking at sort of just reevaluating the way we look at everything we do in life and in the field. I think about just kind of, and again, I know you're not a BST hater, but going back to the idea that we talk about a lot of things in our field and being gold standards for things. And I think sometimes gold standards implies we should stop looking for anything better and stop looking for any improvements. And I love that you're willing to go beyond the gold and sort of see what's out there and see if something else might become gold. Everyone else needs an opportunity for that gold medal, and so I think you do too. So I really appreciate the work.
Thank you. I do really appreciate that. And please let me know if you do use TeachBack. How do you like it, what you don't like, or even any other thing that we talked here? Because, of course, like, we can do some studies in the lab or even in the flight setting, but the more we know how it's actually being used in the real world and the outcomes that you're getting, the more that can guide future studies as well. And I just want to end with that. Doing all of these things alone, as much as I do appreciate your recognition, but there's always like a big interdisciplinary team involved, which makes it more fun to keep going forward and doing research.
Amazing. Andressa, thanks for coming on the podcast. This was cool.
Thank you. Thank you for having me.
If you enjoyed this conversation, check out these episodes that discuss behavioral science applications in the healthcare sector. Episode 19, Health, Fitness, Nutrition, and Coaching Through a Behavior Analytic Lens with Wes Lowry. Episode 33, Addressing Substance Use Disorders, Poverty, and AIDS Prevention Using Behavioral Science with Dr. Srinidhi Subramaniam. Episode 35, Staff Training and Supervision with Dr. Dennis Reed. And Episode 110, Contingency Management with Dr. Bethany Rafe. If you enjoyed this episode, please consider leaving a review on Apple Podcasts, Spotify, or wherever you get your podcasts. And please follow us on Instagram @BehaviorSpeak.